Everyone for the third session of webinar series on role of ultrasonography in critical care. So as we know, the today's topic is going to be ultrasonography of lung in ICU. So before we start, I'm going to give you a little
recording है क्या इसका screen recording?
I'm going to give you a little
We can't hear your voice. करना.
I'm going to give you a little introduction about Is Life Academy and the speaker for today. So the Is Life Academy is run by three of us. This is me, Dr. Sandeep. I am head of critical care in Terna Speciality Hospital in Mumbai. I am teacher and examiner of IDCCM, IDCCN, and also author of a book, MCQs in critical care and clinical cases in critical care. Then we also have Dr. Florence Almeida, who is senior consultant in Fortis Hospital, Delhi. He has over 20 years of experience in critical care. He has delivered more than 5,000 lectures and is author of Critical Care for Nurses book. We also have Dr. Bhavnish Sabharwal, who is head of critical care in Mata Chanan Devi Hospital, Delhi. He has more than 15 years of experience in critical care and he is a faculty for DNB training. And you can follow us on these online links. I am pleased to introduce Dr. Sachin Gupta, who is the primary speaker for today's class. I think Dr. Sachin Gupta does not need any introduction, but for introduction's sake, he is at present working as Director of Critical Care in Narayana Superspeciality Hospital, Gurgaon. These are some of his major achievements. So he has been General Secretary in currently concluded session of ISCCM. He has been North Zone representative. He has been chairperson of ISCCM Gurgaon branch. He has been associate editor of IGCCM. He is also fellow of American College as well as Indian College of Critical Care. He is also co-editor of ISCCM Manual of Ultrasound in Critical Care. He has authored more than 100 publications, including editorials, guidelines, chapters, and research papers. And he is National Principal Investigator for Dissect, Solute, and Resuscitate trial. His area of interest, obviously, are critical care ultrasound, advanced hemodynamics, and extracorporeal therapies in sepsis. So welcome, Dr. Sachin, and thank you for giving us his time. So I'll be handing over the session to Dr. Sachin Gupta. You can share your slides now.
Thank you, Dr. Sandeep, for the kind introduction. So good evening, everyone. And I would be speaking about lung ultrasound and what is the utility of point of care ultrasound in our daily practice. And lung is probably one of the most important aspects that we like to scan on a daily basis. See, as a routine, if you look at your routine ICU investigations, right? Chest X-ray probably is one of the most common investigations that you do. Can we change that practice, or can we gain more knowledge by adding ultrasound to your routine patients? So see, in Harrison in 1992, it was said that the lung is a major hindrance for the use of ultrasound at the thoracic level. The reason is lung is full of air. Air is an enemy of ultrasound. So how can you talk about scanning the lung which is full of air? And that's the reason in 1992 Harrison wrote this, and the very next edition of Harrison had a chapter on lung ultrasound, right? So this is how that modality has been changing in this scenario. In the last 2 decades, transthoracic lung ultrasound has proved itself, and this is one of the most revolutionary diagnostic as well as monitoring and therapeutic tool in the intensive care environment. It provides significant information that can be integrated with the clinical signs and symptoms of these patients. And the pandemic actually changed the way ultrasound was used, of ultrasound, but it gained a lot of importance in the pandemic period. Now, this is an article which said that it's not only a diagnostic tool, it can also be used as a respiratory monitoring tool. And I will show this as we move on. Now let us talk about little sensitivity and specificity of our classical investigation, which is the chest X-ray. So if you look at pulmonary edema, now pulmonary edema in a chest X-ray has a sensitivity of 36% and a specificity of 90%. Whereas ultrasound has a sensitivity and specificity almost close to 95 to 96%. COPD and asthma, it is poorly sensitive and specific in as you look at the X-rays. Ultrasound, again, very specific and sensitive, almost 89% sensitive and 97% specific. Pulmonary embolism. Normal chest X-ray will not rule in or rule out pulmonary embolism. Basically, chest X-ray has minimal role when it comes to diagnosing pulmonary embolism. For ultrasound, you have specific findings, and cardiac findings are very specific, and almost 88 to 90% sensitivity is there. Pneumothorax, the sensitivity of chest X-ray varies because it depends on the exposure, but still it is very poor. Almost you will miss 1/3 of the patients when it comes to diagnosing pneumothorax with the chest X-ray, whereas ultrasound has a sensitivity and specificity touching almost 100%, which means you cannot miss even a smaller pneumothorax in this patient. Pneumonia, again, 38 to 76% sensitive, whereas ultrasound will give you a very high sensitivity and specificity, almost touching 95%. Pleural effusion, to diagnose a significant or any pleural effusion on a chest X-ray, you require a volume of 175 to 525 ml on a supine X-ray, whereas ultrasound can detect as low as 5 to 20 ml with a very high sensitivity and specificity. And this is where ultrasound becomes important in our daily critical care practice, because you will not miss the diagnosis. You will rather diagnose them much earlier than your classical investigations will start showing them. So there was another study which looked at comparative between auscultation chest radiograph and lung ultrasound, and I will not go in those details, but if you look at lung ultrasound findings, everything was above 92 to 93%, whereas the auscultation and the chest radiograph varied because auscultation has an inter-individual variability and the chest radiograph did not have that kind of specificity and sensitivity. So what are the uses of lung ultrasound? Basically, you can diagnose normal lung, then any pathology that is on the surface of the lung. So you can have pneumonia, you can have pulmonary edema, interstitial syndrome, you can have pleural effusion, atelectasis, pneumothorax, pulmonary embolism. You can actually rule out endotracheal or endobronchial like thoracocentesis. Principle. Lung ultrasound is based on the principle acute disease. Use the aeration of the lung. And once the aeration of the lung is changed, there will be
I think there is some issue with your internet. You are muted.
I was not able to unmute myself. Yeah. So the principle of lung ultrasound is that any disease that happens will cause a reduction in the lung aeration. Once there is a reduction in the lung aeration, there will be a change on the lung surface. This change will generate certain artifacts, and what we interpret in lung ultrasound is artifacts. So lung ultrasound in nutshell is interpretation of the artifacts which are generated, right? And this is how we differentiate various organs or various pathologies. So which probes are required? Now, for scanning the lung, either you can utilize the curvilinear probe or the linear probe, and it purely depends on what is the what is the kind of patient. With obese, morbidly obese patients who have a lot of hair, curvilinear probe will be a better modality. Edematous patients, curvilinear probe will be a better modality. Thin, lean patients, very thin chest, bony patients, linear or a vascular probe is a better modality because you will be able to fit it between the rib spaces. So it purely depends on what is the kind of patient that you're looking at. Secondly, when you're scanning your lung faster, a curvilinear probe will be helpful because the scanning area is wide. When you want a detailed evaluation of a particular rib space or a particular lung zone, then you convert to a linear probe, because this is how you will come from a broader view to a very narrow view. So both the probes can be utilized in scanning the lung. This is how you place the lung. So there are two orientations. One is the transverse and the other is the horizontal. Transverse means the first image, if you can see, you are placing the probe in such a manner that you are trying to cover two ribs, one above the other. But when you're between the rib space, right, so you are doing a detailed evaluation of that rib space. So this is how you place your probes. We start scanning vertically from top to bottom. Wherever we find a pathology, we convert our probe to a horizontal probe, because then you like to have a detailed evaluation of that particular area. Secondly, we hypothetically divide each lung part into 6 zones. So 6 on the right hand side, 6 on the left hand side. So you have 12 lung zones, you can call it. We call it zone 1, 2, 3, 4, 5, 6, and it is nothing to do with what you classically talk about lung zones on the chest radiograph or on the CT scan. It has nothing to do with it. There is no correlation. As I said, this is hypothetical. So what you do is you draw a vertical line at the lateral sternal margin, another vertical line at the anterior axillary line, and the third at the posterior axillary line, divided at the level of the nipple. So you have the zone 1 and 2, which is above and below the nipple. Then on the lateral side, you will have zone 3 and 4, and posteriorly at the level of the scapula, you will have zone 5 and 6. Now, if you look at this, understandably, an ICU patient who is bed bound, who is, let's say, on a ventilator, on a BiPAP, on an HFNC, where we will have majority of findings, we will have majority on zone 4, more dependent, and posteriorly zone 5 and 6, again dependent. So what we should do as a clinician, at least once in a day scan your zone 4, 5 and 6. You will come to know, is there a pathology, is there an atelectasis which has started in this patient, a morbidly obese patient coming after, let's say, an orthopedic surgery, nothing to do with the airway. But you find that the next morning, patient which was doing absolutely fine in the night, 98, 97 saturation, morning 92, 93 saturation. Very small dip, but there is a change. What has happened? You can easily scan and say, oh, there is atelectasis. This patient requires only incentive spirometry, probably. It will open up. So these are the small, subtle findings that you can come to know. So always scan once at least zone 4, 5 and 6, because these are the surface imaging technique. So very simply, if there is air, it will come up. If there is water, it will go down. So it follows the laws of the gravity, and we will see this. Now, when we scan the lung, we will be looking at certain real images, or could be pathological, and then majority of the images are artifacts, and there are certain normal artifacts also, and then there are pathological artifacts. And as I said, lung ultrasound is based on the analysis of artifacts. So whatever the lung ultrasound beam generates, we will interpret that. Now, this is the first image that you can generate, and if you can appreciate, I can see two rib shadows. So it is covering the two ribs. The upper part, the part, wait, I will have my pen. So this particular part, which is non-moving, is the skin, subcutaneous tissue, and the ribs. These are the real images because there is no air here. This is what you see on an ultrasound. Beyond that, what you see as a to and fro structure, right, is basically the lung sliding. Now, this to and fro movement is the lung sliding, which means the parietal and the visceral pleura are sliding over each other. That's the reason we say lung sliding. Now, here there is air. Lung sliding means the lung is expanded. Lung sliding means it is contributing in ventilation, whether this is spontaneously breathing patient, intubated, non-intubated, it has nothing to do with that. This means this part of the lung is contributing in ventilation of the patient. So, there is air. Ultrasound will not show anything beyond air. We know this. There is no second thought on it. So it will start generating certain artifacts as soon as your ultrasound beam hits this pleural line. We will interpret those artifacts. So if you look at this, I have written real-time images. So real-time images means skin, subcutaneous tissue, ribs. Beyond that, once you see the pleural sliding, whatever you see is an artifact, and we will interpret those artifacts. So this is how the image is. So a normal lung, if I have to say this is normal lung, there has to be a pleural line, the line which was moving to and fro, which we also call as pleural sliding. Then we will call as certain lines as A lines. I will describe those lines. What do you mean by A lines, and how do you say that this lung is ventilating? Now, this is a normal sliding lung, the to and fro movement of the pleura on each breath. If you can appreciate here, the topmost line is the pleural line. Then you see a small horizontal line, almost like a Xerox copy of the top line. Then you see another horizontal line at the bottom. These horizontal lines are called as A lines. A stands for air, so we call this as A lines. These are artifacts. Because the ultrasound beam has reflected back from the pleural line, it generates certain artifacts. Now, A line means there could be couple of diagnoses. A lines could be in normal lung. So, A line can be in normal lungs. Somebody with breathing difficulty but still having A lines, it could be COPD asthma. I'll show that as we move on. Then we also have A lines in pneumothorax. A stands for air. So even if you don't have pleural line, you can have A lines. We will see that as well. So A line means normal lungs, COPD lungs. It could also be pneumothorax lungs. So this to and fro movement is called the lung sliding. If I put an M mode, now you have a motion mode in your ultrasound machine, an M mode. If you put an M mode, you will have this kind of vertical line. It could be a solid line, it could be a dotted line, depending on the machine that you are using. You put this M mode on this lung sliding. What you see next is this kind of image. And this image is called as a seashore appearance. Why do we call it seashore? So if you stand on a sea, right, what you will see calmer waves, very calm horizontal waves from a distance. And this granular appearance is the sand on the beach. So this is called as a seashore sign. This represents that this lung is normally sliding. Why do you have this seashore? Now, if you look at the topmost image where I have put the M mode, the M mode starts from the skin. So your skin, subcutaneous tissue is a non-mobile structure, and it is represented that way by these horizontal lines, which we call as waves. The lower part, as soon as this M mode hits the pleural line, you will have sliding, you will have reverberations, you will have movement in the alveoli, and these moving alveoli give you this granular appearance, what we call the sand. So this is the reason we say this is a seashore appearance. So this is the skin and the subcutaneous tissue. This is the pleura, and this is the aerated lung. So I hope this is clear why M mode shows seashore sign on a lung sliding. We spoke about A lines. So as I said, these are artifacts. Anything beyond pleura is an artifact. So these are reverberation artifacts or simply artifacts. Lines which are parallel to the pleural line. So they always will be parallel to it. and they are separated at a regular intervals, and this regular interval is actually equal to the distance from the skin to the pleura. This is like a ping pong ball. So if you remember, we used to throw that ping pong ball and used to come back with the same height and the same pace back to us. So ultrasound beam behaves like a ping pong ball the moment it hits the pleural line. As soon as it hits the pleural line, it starts reflecting back. In that moment, it starts generating these artifacts which are equidistant in nature. So let's say if the distance from the skin to the pleural line was 2 centimeter, you will start seeing these A lines 2 centimeter beyond the pleural line. So that will be the first, second A line. So it is A reflection, 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 reflection. This is how it keeps going on. So as I said, this is seen in normal aerated lung. This could also be seen in asthma and COPD, and this could be seen in pneumothorax. The difference is in COPD asthma, you will have the lung sliding. In pneumothorax, you will not have the lung sliding. I'll describe that as well. So the another lines are called as B lines. Now we had A lines, these are B lines. B lines are pathological lines. These are not normal. So A lines could be normal. B lines are never normal. They are always pathological. B lines, in simple words, represent that the air from the lung has reduced and the water component in the lung has increased. Now we can think very easily what are the conditions where the water content of the lung is increased. Pulmonary edema is one condition. Consolidation is another condition. Lung contusion is another condition, right? These are the three major conditions where the the water content of the lung has increased. Now there are certain characteristics of B lines. So B lines will emerge from the pleura. So the pleura which was sliding, the B lines will start from there, and they are like laser show. So if you put a laser light, they diverge from a narrow end, they become diverse. So it is like a laser show. It reaches the base of the screen. So if you can see the image which is at the bottom, it is reaching the base of the screen, right? In this activity, the A lines which were there are completely erased. So you will not have any A lines. So as I written, emerge from the pleural line. They are hyperechoic, so they are whitish in nature. They move with the pleura. So because they are emerging from the pleura, they will move with that movement. Well-defined laser-like show, spreading to the edge of the screen. They do not fade. They go to the base of the screen. They erase the normal horizontal A lines, and this denotes that there is deaeration, because if the air has been reduced and the water component has increased, in clinical scenario it is deaeration. So B lines are always pathological in nature. So if you have this kind of image in your patient, as if let's say your patient is becoming more and more hypoxic, just do the lung ultrasound and see what was probably the first image in the morning, was the second image in the afternoon, could be the third image by the night. This means that your patient is having a leaky syndrome. If let's say the patient was not on anything, the alveolar fluid is, the patient is getting flooded, right? And that's the reason the B lines, which was minimal to more to coalesced B lines, this is an increase in the water content, and this is the reason your patient is not doing better. Reverse can also happen. You start with the third image, you probably gave CPAP, BiPAP, ventilation, diuretic, whatever you did, you could see that there is reduction in the B lines, right? And your patient is doing better, and that is the reason I said this can also be used as a respiratory monitoring tool. The third lines are E lines. Now, E lines and B lines, they look very similar. The only difference is the B lines were starting from the pleural line. The E lines represent emphysematous lines. Emphysema, surgical emphysema or subcutaneous emphysema. The moment I say subcutaneous, it means it is under the skin. It is not at the level of the pleura. So if it is under the skin, it can't originate from the pleura. It is above the pleura. And as air is an enemy of ultrasound, so the moment it hits the emphysema or air under the skin, it starts generating artifacts. So they are similar to the B lines, but the difference is they originate from the skin, not from the pleura. And as they are not originating from the pleura, obviously they won't have the to and fro movement of the pleura, and you don't see any part of the lung. So subcutaneous emphysema is the only I would say, contraindication to lung ultrasound. So if you have subcutaneous emphysema at any particular area of the thorax, you will not be able to perform a lung ultrasound in that particular area. You have put an ICD, and let's say the patient has emphysema. You have put an ICD on the left hand side and patient has surgical emphysema. Probably you may not be able to do an echocardiogram there, right? Transthoracic, because there is air. So this is the only contraindication of ultrasound. Then you have Z lines, and Z lines are not pathological. These are created by the performer, right? And they are because of the irregular movement or at an angle. If we put our probe, the only difference is they do not go to the base of the screen, they fade in between. So this is how we differentiate it from the B lines, not a very significant lines. Then there is a terminology called lung pulse. Now, what is lung pulse? See, when right now the lung is having two kinds of movement in all of us. One movement is the cardiac oscillations are getting transmitted to the lung. So there is pulsation in the lung. So every heart wise, the lung will pulse, lung has to expand. So lung will be sliding, the sliding that we described. Now breathing is a more prominent movement as compared to the transmission of the cardiac pulsation. So what we see in a lung is only sliding. We don't see the pulsations which are transmitted. Now, how can I see the pulsations which are transmitted? It means I have to stop breathing. I have to stop my sliding. Then only I can see my cardiac pulsations getting transmitted. So conditions where I stop breathing. Condition number one, if I have done an endobronchial intubation, my tube has gone to the right hand side, right lung, which means right lung is getting ventilated, but the left lung is not getting ventilated. What I will see? I will see my cardiac oscillations being transmitted, and I can see the lung pulsating on the left hand side. A mucus plug will obstruct that ventilation. I can still see that. Or as I said, I stop breathing, which means apnea. So lung pulsation is a normal phenomena. Lung pulse is an abnormal phenomena. Understand it. It is a very minor difference. But if you read literature and you find lung pulsation, that is normal. It is happening in every one of us. Right now also it is happening. Lung pulses when either you stop breathing or there is an endobronchial intubation. So you have this lung pulse on the other side where the tube has not gone, which means the ventilation has stopped and now you start seeing only the transmitted pulses of the heart. This is how it is. And if I put an M mode here now, I won't see a seashore here. I would see these vertical borders which represents the heart rate of the patient. That once I see these vertical shadows, you can actually say this is the heart rate of the patient if you start counting them. Right. So on the basis of the various artifacts, there are certain lung profiles that are there. And if you read the literature, you will come to know one is called as an A profile. A profile means the lung is sliding and there are A lines, absolutely normal, healthy lung kinds. A dash, any dash, if you read the profiles, anywhere where it is written dash, it means the lung is not sliding, as simple as anything. So when you say A dash, A profile, but the lung is sliding is abolished. Then there is B profile, means these lung rockets are there, but the lung is sliding. The moment I say B dash profile, the lung sliding is absent, but there are these rockets which are there. There could be AB profile and then there is C profile, what we call for consolidation. So these are the various profiles that we discussed. The first is A profile where you have an A line and the lung is sliding. The second is A dash profile where you classical for pneumothorax. Then you have a B profile where B lines are there, but the lung is sliding. In a B dash profile, mostly it is in a lobar pneumonia that you see those B lines, but the lung does not slide. And in the last C profile, you see a thick consolidation. So these are the various profiles that are there on the lung ultrasound. Now let us talk about now clinical applications. We have heard about various profiles, various lines, what is lung pulse and so on. Let us utilize this in practical issues. As said, endobronchial intubation. So done an intubation and the tube has gone on the right side. We will see the lung right. We will not see the lung pulse. But what you see on the left hand side is the lung pulse. You can see and you will have an immobile lung, which means the lung is not sliding. You will get confused that both look sliding. So just closely observe this vertical laser kind. They are at a static point. They're just pulsating. They're not moving. They're just pulsating. And that's the reason we say this is on the left chest, you see a lung pulse. On the right side, you see lung sliding. This is the difference. And this is how your endobronchial intubation can also be deciphered. Then pneumothorax, 100% sensitive and specific case when it comes to ultrasound. Now, understand how ultrasound generates this artifact in pneumothorax. So as I said, air is an enemy of ultrasound. The moment it hits the pleural line, it starts generating artifacts because after pleura, there is air. Now, suppose I bring air above the pleura, which means in pneumothorax, the air has leaked out. You don't see the lung and there is air all around outside the lungs. Which ultrasound does not know what is pneumothorax. Ultrasound does not know what is pleura. Ultrasound knows if I have air, I have to generate artifact. Ultrasound knows only one thing. So the moment I put my ultrasound, I cross my skin and what I see, the first thing is air. I will start generating artifacts. Now this is not pleura. This is air outside the pleura, which is not sliding. So here you come to see the A dash profile. You see these A lines, these horizontal lines, but you don't see any lung sliding. So the lung sliding is absent. You use the lung pulse is absent because see lung sliding, lung pulse, B lines, they are all originating from the pleura. When I'm not seeing the pleura, all these artifacts will not be seen, as simple as anything. So no lung sliding, no lung pulse, no B lines, only A lines are there, right? This is classical for pneumothorax. And then if you are lucky, and I would not say lucky, if you are lucky to have a pneumothorax and you do a lung ultrasound, you will see the most important characteristic, which is the lung point, the point where there is breach, the point where the pneumothorax has originated. If you see even one B line, you can rule out pneumothorax because the B lines originate from the pleural line. The moment I see the pleura, it means वहां पे कुछ फटा ही नहीं है. There is no leak. The air has not leaked out. There is pleura at the surface of the lung, right? So if I see one B line, there is no pneumothorax. And this is what I was talking about, lung point. So schematically, if you look at the left-hand side, if you start scanning your lung from the top, from the area where there is blood, I will not see any pleura. I will not see any pleural sliding. It corresponds to this part of the lung. The moment I go down, 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 and I reach a point or a junction where the pleura is attached, this is the junction. You start seeing this junction on an ultrasound at a point where one part of the lung is sliding, the other part of the lung is static. This point is called as lung point. Lung point is classical, pathognomic of pneumothorax. So why is this important? This is important because now you know that this is where my lung has breached. You can plan your intercostal tube above that lung point. Blindly, you may actually put an intercostal tube even in an area where the pleura is not detached, which means you can harm the patient, right? So lung point can also be a marker where I can put my intercostal tube. That is one. Second, once you have put an ICD, you can actually see the regression of the lung point. The lung point, which was probably at the fourth, fifth intercostal space, after your ICD has started regressing, and there would be a moment where you will not see a single lung point, which means my lung has fully expanded. You start seeing the entire sliding, which means my lung has expanded. So lung point also acts as a monitoring tool. You can scan and see where my lung point is heading towards. So this is very, very important when you diagnose pneumothorax. Always try to find lung point. Then there is a syndrome, we call this as an alveolar interstitial syndrome. And this is basically B lines, those rocket lines, which means extreme deaeration of the lung. And then on the basis of that, that is this a pulmonary edema or is this an interstitial lung disease pattern? It purely depends on the distance of the B lines, but that's not so important. We say if you see B lines, which means your lung is wet. If you are giving a lot of fluids, be very, very cautious. You may need to give diuretic, you may need to give BiPAP, you may need to do something else, because your whatever you're doing is leaking inside your lungs. And so if you have a bilateral B line with somebody with a history of a poor heart function, this is pulmonary edema unless proven otherwise. And this is how your one side of the lung would appear, that the B lines are there. They are moving with the pleura, originating from the pleura, going to the base like a laser image, erasing the A line. So this is the classical description of the B lines. And based on all these things, the international evidence-based recommendations for point-of-care ultrasound were published in 2012, where they said there is a level A recommendation when it comes to pulmonary cardiogenic pulmonary edema, that you can semi-quantify the disease severity by counting the number of B lines, that is one. And it also helps in monitoring the response of the therapy, that is two. And if the patient is improving or the number of B lines are reducing, you can actually say, is this reaeration or not? So basically, lung reaeration can be demonstrated by a decrease in the number of B lines. So basically, you are also looking at it as a monitoring tool. And then there are n number of articles about how to diagnose pneumonia, quantify pneumonia, look at the monitoring part. This is how your consolidation generally looks on an ultrasound. So remember, when we talked about consolidation in our MBBS days, we used to say hepatization, gray hepatization, red hepatization, which meant the lung was always compared to the liver. It should look like liver. So the consolidation on an ultrasound also looks like liver. So this is the liver, and the lung, which is totally collapsed, looks like liver. And that's the reason we used to use that word. This is one way of looking at the consolidation. Now remember, this image of the lung is a true image. Why it is a true image? Because the air has been completely absorbed out of that lung tissue. So there is nothing for an ultrasound to generate an artifact. The ultrasound penetrated your skin, subcutaneous tissue, then it had fluid, which is pleural effusion. Fluid is an excellent medium for ultrasound to pass. That's the reason you are able to put your IJVs and your subclavians and your females, because you see the vessel very clearly. Entire air has been absorbed from the lung, and so you see a true image of the lung. This is the another image, what is called as dynamic air bronchogram. And when we say dynamic, this is not a contrast. Remember, this is just air going in and out. In this consolidated lung, in consolidation, the alveoli are open, but the lung has been absorbed, the air has been absorbed. So what happens? Every time the air goes in, it will appear like this white in color. So this is air going in and out. This is called as dynamic air bronchogram. If you find it anywhere, probably zone 4, zone 5, zone 6, this is very, very classical of consolidation. The third sign of consolidation is called as the shred sign. And when we say shred, what do you mean by shred? Shred means uneven. Now, if you look at this sign, the topmost part is very smooth and it is not contributing in ventilation. The lowermost part, where you see this irregular white line, this is the B line, or this is the pleural line. Ideally, the pleural line should have been at the top. What has happened is the uppermost part is consolidated. It is not contributing in ventilation. And the pleural line has gone down. So which means from here onwards, the ventilation is taking place. This is called a shred sign. Now, this is again a monitoring tool. You do your therapy, whether antibiotics, ventilation, whatever you're doing. If this shred line is going down and down, which means your consolidation is increasing, more and more solid part is increasing. If this pleural line starts going up and more towards the surface, which means whatever you are doing is helping your patients, and now more and more lung is participating in ventilation. So this is the difference, and this is how you monitor the lung ultrasound, the consolidation with the help of shred sign. Then ARDS. Now we all know ARDS is a non-homogeneous disease. So you will have all patterns of the lung. You can have normal lung, you can have occasionally B lines, you can have coalesced B lines, and then what we call as a very important sign is called subpleural consolidation. When I say subpleural, the name itself says just below the pleura, and the consolidation, which is this shred appearance. And this is how the subpleural consolidation will appear. Irregular pleura are small areas of consolidation. These are various shreds together put together. So what we saw is a shred sign there. These are all areas of shred sign, small areas of shred all put together. And if you find this in your lungs, this is classical of ARDS. This is named as subpleural consolidation. You will not find this in any other disease form except ARDS. And then you see a lot of B lines, right? So as per the guidelines, the 2012 recommendations, you can semi-quantitatively assess them. You can have normal pattern lung, you can have multiple spaced B lines, you can have coalesced B lines, and then obviously you will also have consolidation. And this is how you differentiate between acute cardiogenic pulmonary edema or ARDS. Both will have an acute course, both will have B lines. The difference is in acute cardiogenic pulmonary edema, the B lines are smooth, whereas in ARDS, the pleural surface becomes absolutely irregular, and the subpleural consolidations are present, which is not there in the case of acute pulmonary edema, because it is not a disease of the lung. Acute pulmonary edema is a disease of the heart. ARDS is a disease of the lung. So the lung anatomy has to get distorted. Understand it this way, right? Then you have atelectasis. Now atelectasis looks very similar to consolidation. It is very difficult to differentiate. The only way to differentiate is, see what happens in atelectasis, the air is trapped inside the lung. Whereas in consolidation, the air is not trapped inside the lung, and that's the reason we were seeing those dynamic air bronchogram, air coming in and going out. In atelectasis, the air is trapped inside the lung, which means whether you are inspiring or you are expiring, you will see small tiny dots of air in both the phases of respiration, right? And this is how you differentiate between atelectasis and consolidation. And so we call this as a static air bronchogram, because they're always there. They're not going in and out. They're not dynamic in nature. And so we call this as a static air bronchogram. Then you have pleural effusion. So this is like a plankton sign or a freely floating lung in massive effusion. You can drain this effusion very simply. You put an M mode, and if you have this sinusoid kind of pattern, this pattern tells us that you can safely put a needle to drain this fluid, because the lung, even in inspiration, is not touching the pleural surface. So it won't hit the needle every time the patient breathes in. So this is the way you try to make the procedure more safe. You can quantify this. This examination is now losing more and more relevance. So to put all this together, you have a protocol, and this is called as the Blue Protocol by Professor Daniel Lichenstein. He is considered father of lung ultrasound. So what do? You first look at your lung, and is the lung sliding? Answer should be yes or no. If you say yes, the lung is sliding, then you look at the pattern. Is it an A pattern or is it a B pattern? And this is for patients who are in respiratory distress. So somebody with an A pattern, remember when I said lung sliding A profile, which meant either you can have a normal lung, you can have a COPD lung, or you can have a pneumothorax. So when you say my lung is sliding and I have an A pattern, what am I ruling out? I'm ruling out pneumothorax, as simple as anything. Because in pneumothorax, the lung sliding has to be absent. So when you say lung sliding and it is present, then you look at, is it an A pattern or a B pattern? You say it is bilateral A pattern, but remember your patient is in distress. So when you say bilateral A pattern and your patient is in distress, always look at DVT. and your cardiac signs, and if those are present, this is pulmonary embolism. Again, remember, in pulmonary embolism is a disease of the heart, it is not a disease of the lung. But if you say no, there is no DVT, then you look at and there is no consolidation, it is COPD and asthma. That's the reason patient is in distress. If the lung is sliding and you say this is bilateral B lines, pulmonary edema is the only disease form which can have bilateral B lines, unless or until you have bilateral consolidation, right? Which is again not a very common thing. So if you have bilateral B lines with lung sliding, you are talking about pulmonary edema. You have unilateral B lines, you are talking about pneumonia. If your lung sliding is absent and you have A lines, and if you find a lung point, you're talking about pneumothorax. So this is how simply you can actually think about by first thinking what is the lung sliding status of this patient. We can actually, titrate our ventilation strategies by looking at various recruitment maneuvers, where to set the PEEP, and how to wean these patients. There are techniques. We will not go in that detail. There is one more protocol called as the false protocol, which is fluid, which is assessment, and this is limited by lung ultrasound. So what you do is, that blue protocol is for respiratory distress. This is for circulatory shock. So patients in circulatory failure, what you do is, just 1 second. आज मैं 5 मिनट में कॉल करूंगा. So what you do is you do a simple sonography and you look at, are there any signs of tamponade of pulmonary embolism. You are doing an echo because you want to rule out one cause of obstructive shock. If that is not there, we do the blue protocol and we see, is there pneumothorax, which means is there a lung point, or there is absent sliding with an A pattern. You say no, that is not there, which means you have ruled out obstructive shock. Patient is in shock. You give fluid and see what is the lung status. If the lungs are leaky bilaterally, then this is probably a pump failure, and that's the reason we say cardiogenic shock. If the patient is not in pump failure and you give fluids, the patient is improving, then probably this is hypovolemic shock. But patient who started with an A profile now started having B lines, this is usually septic shock, which is a leaky capillary syndrome. So this is how you put the false protocol. So as I said, limitations, it is a surface technique. So if you ask me, can I see a cavity inside the lung? No, sorry, I can't see a cavity inside the lung because there is lung above the cavity. So my ultrasound will not penetrate that part and it will start reflecting back. Do not replace any existing modality with ultrasound. It is an added armamentarium. I am not asking you to throw away your stethoscopes, right? If you are utilizing it, please use it. This is an added armamentarium. It does require some formal training, but still the learning curve is not so steep. It's a very, very small learning curve. Obese patients will have a difficult window. Yes, you will require more practice in generating an optimal image. As I said, subcutaneous emphysema is the only problematic area where you cannot scan that particular area where subcutaneous emphysema is there. So routine use of ultrasound is very, very important. And yes, it can in certain stages be an alternative to bedside radiograph. You need not do an chest x-ray for every small little thing that you do. The learning curve is very small and it has a huge cost and a time saving potential. Once you learn it, you will start enjoying it. You will do it on a daily basis. In my ICU, my ultrasound machine goes with my rounds on almost every single patient. Once I have scanned it, we know what were the findings yesterday and we come to know what are the findings today. You can actually compare it. Is my patient improving, deteriorating, or a new finding has cropped up, right? So once you learn it, it becomes very, very handy and you actually become dependent on it. I will not put shy away from saying that. One of the most promising modality, and I request if you have an ultrasound machine in your respective ICUs, please utilize this, scan your patients on a daily basis, and I promise you will become much more wiser in treating them. Thank you so much.
Thank you, Dr. Sachin. I think this was very, very interesting and very, very useful session today. I am sure everyone must have learned a lot. And I completely agree with you that ultrasound is definitely one of the things which are, I would say, not, it is a must thing. I mean, everyone who is working in critical care now has to understand, has to know it. It is not an optional thing. And I think there is no steep curve. I mean, curve is steep, learning curve is there. You won't need too much of time to learn, and it gives you real life, real time information, which is very useful. I think we have some questions. I think you have answered how to differentiate cardiogenic from
Cardiogenic. And
non-cardiogenic.
so
You have
how to
covered it.
calculate the pleural effusion? So see, the way to calculate the pleural effusion is we calculate the interpleural distance, right? The one pleura which is attached to your diaphragm, the other pleura which is on the lung, and what is the distance of that pleura, and you multiply that by 20, and that's the rough approximate number. But again, it depends. Is it an anterior effusion? Is it a posterior effusion? So, on an average, see, what we clinically see is when you want to tap a fluid, with every breathing, what is the lung status? If the patient is breathing and with every breath, the lung is coming to the surface, um, it is not an easy tap. It can be a dangerous tap, because every time the lung will come up, the moment you are putting the needle, the lung is going to touch your needle. Understand it. Even if you are putting a pigtail, a leader cath, or whatever, at one point of time, there will be a needle in the chest cavity by the time you're railroading your guide wire and then you're putting it. So if with every breath the lung is coming up, be very cautious and do it only if you are actually expert in doing it. Otherwise, yes, if the lung is not coming in, you can safely tap it, and that roughly means you are 500, 600 ml of effusion. This is clinically what I'm talking about. If you really want that number, calculate the interpleural distance, multiply that by 20, and look at the volume. So somebody has asked diaphragmatic excursion. See, we purposely did not keep diaphragm here. It's a lengthy topic in its own sense, right? So I will not be answering that, but yes, you calculate the diaphragmatic thickening fraction and so on. So that's the reason we did not cover diaphragm here.
We will cover it separately.
Yeah.
Because it cannot be clubbed up. All the things cannot be clubbed up together. Acha, Dr. Sachin, I personally have two issues to
Please.
understand from you. One is, as you said, it is sometimes difficult to differentiate between you see a effusion and there is some lung. Now it is difficult to differentiate whether this is consolidation, subpneumonic, pneumonic effusion, or a passive atelectasis. Is
So
there
I
some
agree,
easier
because
way?
see, the weight of the fluid will collapse the lung,
Correct.
right? So if you feel that the effusion is enough to be tapped, what we do is, yes, tap, because see, you can have mixed picture in that lung. You can have an atelectasis, you can also have a consolidation. Aisa nahi hai ki you can have only one thing at a time.
Correct.
There could be a passive atelectasis because of the weight of the effusion. If you're tapping it, you will see majority of the times the atelectatic lung will open up. If you are not tapping it, and if your patient is on any form of therapy, NIV or ventilator, if you give some amount of PEEP, if you just try to recruit this lung, you will easily come to know, is there a recruitable lung or not, which means, is there an atelectatic lung in that form? If there is atelectasis along with consolidation, the atelectasis will open up, the consolidation will stay the same. If there is pure consolidation, nothing is going to happen. And then you know this is consolidation, probably a pneumonic effusion. I need to tap it for my diagnosis and so on and so forth. So this is how you can differentiate it. If the patient is not on any therapy, just ask that patient to do an incentive spirometry. That will also open up the atelectatic part if there is atelectasis.
After you drain the effusion, obviously.
Yes.
Okay. Second part is if there is a anterior pneumonia. So on ultrasound, it is going to look like a sliding
So,
spine with vertical
B lines.
lines, a lot of B lines. That tells you that there is a consolidation. And if they are on the both lung, then probably it is more of pulmonary edema, right? Okay.
So see, when we talk about anterior pneumonia, lobar pneumonia, anywhere else, you will have that finding only in that particular lobe.
Correct.
If that is in zone 1 or zone 2, only in zone 1 or zone 2 you will have findings. Zone 3, 4, 5, 6 may not have any finding, which tells me that this is consolidation.
Correct.
If I am having pulmonary edema, zone 1, 2, 3, 4, 5, 6, it doesn't matter. You will have B lines in all zones bilaterally.
And lastly, the diagnosis for collapse point and COPD and asthma is more of a ruling out things
So it is
rather.
more of a ruling out. See, PLAPS is actually very posteriorly. So we say zone 5 and 6, you scan, you may see a PLAPS point. So a small area of consolidation could be there. But otherwise, it is differentiation between consolidation and COPD at the posterior part. That's the only difference.
Okay, so these are the difficult areas for most of us. Bhavnish, you want to participate? You want to say something?
Hello.
Yes, Bhavnish.
Uh, First of all, thank you, sir, for enlightening us with the so simplicity and this difficult topic. So, I just want to confirm that is it possible to decrease the daily routine X-rays if we are using ultrasound in our ICUs? And secondly, if the patients where we can't do routine X-rays like in pregnant females, patients presenting like with heart failure, asthma, COPD, there are a lot of pregnant females are presenting in our ICUs. So we can't do X-rays daily routinely in these type of patients. Okay. So ultrasound can be helpful in these type of patients.
Yes, ultrasound can be helpful. So see, even in my ICU, let's say patient comes from the emergency, by default there is an X-ray which has been done, right? I don't know why, but it has been done. You see those X-ray and you see an ultrasound. Now once you see an ultrasound and you find there is nothing in the lung or there is small little effusion in the lung, right?
Mm.
Patient is okay, probably a half liter, 1 liter, or not even on oxygen. The next day we
Mhm.
don't do an X-ray, just a routine ultrasound at the bedside during the rounds. What is the status? Secondly, once you decide that I want to, now the another clinical application of what you asked, somebody says, let us do an HRCT of this particular patient, right?
Right. Mhm.
You see, you do an HRCT, you find an effusion.
Okay.
Now
Mm.
you say, we want to tap this effusion. You will tap this effusion. Now you will say, I want an X-ray post tapping. What
Right.
we do is, we do the scan first, ultrasound. I find an effusion, I drain the effusion, and then I send my patient for a CT for a particular reason. Once I do this, I know the true architecture of the lung, because on a CT you will still have a collapsed lung. You don't know whether you're dealing with atelectasis, whether you're dealing with a consolidation,
Mhm.
right? So we do
Right.
it other way. We tap this patient, we remove the fluid, mujhe pura lung ka architecture, I send it for this CT. If that CT has to be done, I will know, is this atelectasis, is this consolidation, or this was absolutely normal lung, just the weight of the fluid was there. Very common in CKD patients, very common in liver disease patients. They tend to have these hydrothoraces and everything, right? So
Mhm.
this is how you can actually reduce the number of investigations. For ventilated patients, let's say somebody has been ventilated for an SAH, no issue with the lung.
Mm.
We don't do chest X-ray daily.
Right.
We just scan our lungs. The lungs are sliding. There is no B lines. The posteriors are fine. My curtain sign is okay. I'm happy. I don't want to scan this. I don't want an X-ray on this lung.
Okay.
But that confidence has to be there in that individual, that you know what I'm doing, I know it. And obviously, if you keep doing it, the other specialities also start understanding that what they're talking is sense.
Got it.
Mhm.
And
Right.
routinely, how much time do you take to scan one patient? Because you scan
So,
all the patients in
uh, no, so now it does not take that much time. But if somebody, let's say today a patient is getting admitted, now I am at home, so tomorrow morning I will, during my rounds only, so what we do is, a junior is giving me a handover, I say, ultrasound Leo, let us scan. So somebody would scan. If I want to particularly scan, by the time I'm hearing the history, I have scanned that patient. So it takes 5 to 7 minutes, because we do a rapid scanning first top to bottom, and if I see, okay, posteriorly, we just scan and we know, okay, this is effusion, this is consolidation, atelectasis, this is B lines, let us formulate our treatment. So not more than 5 to 7 minutes per patient. And if I've scanned that patient today, I know my problem areas tomorrow in that particular patient.
And is it helpful in ARDS patients? Are you doing regularly in ARDS patients when you are applying PEEP and
Yes,
ventilating the
yes,
patient?
yes,
Regularly you
yes,
are doing. No?
yes. To know the status of the lung, to know new areas are coming up or the areas which are already affected are reducing.
Okay, I think this is a great thought, and I think we should start working to reach that stage.
Yes. Thank you, sir. Thanks a lot.
I think
Thank you for joining.
we don't have any specific question. I think we can conclude. It was a really wonderful session, Sachin.
Thank you.
Thank you
Thank
so
you.
much for your time.
Thank you. Good night. Good night,
Good
everyone.
night.
Okay. Okay, so I'm ending for everyone. There will be another session which we will soon announce. It will be on the next section of ultrasonography series.